Look, it looks a whole lot like meningitis. High fever, photophobia, fatigue, headache, seizures,
Same as meningitis.
change, motor dysfunction. The good news is we can figure out what it is if it's a viral infection and give you antiviral therapy. I remember when we didn't have any antiviral therapy. You were just shit out of luck. Parkinson's disease. Anybody know somebody who's rather famous who had early onset Parkinson's disease? Michael J. Fox. Usually this goes after people past the age of 50. Michael got it when he was in his late 40s, late 30s, early 40s. All right, the first thing you're going to notice on Parkinsonian disease is they're going to have a blank facial expression. They look like they're wearing a mask. Here's an easy way to remember it, my dears, the difference between Parkinson's and dementia. Are you ready? Parkinson's, the body fails. The mind stays intact. Dementia, the mind fails. The body stays intact. That's why patients who have Alzheimer's dementia get put in lockdown units. Because they think they're 14 again and they gotta go to the high school dance. And they go to walkabouts. They do, they'll take off and you're like, damn it. You'll see a stooped posture. They may end up with a tremor. You may see something called pill rolling. Okay, I caught myself doing this the other day. I freaked out. Pill rolling, you may see picking. Okay, and then they love to do what I call the Parkinsonian shuffle. Well, they'll sit there and they'll try and walk. When I was a PT, I had this one little gal named Agnes. She was adorable. She was like 80-something years old. She had severe Parkinson's. She's got her walker, and I said, "Come on, let's go." Put the walker in front of her. She starts doing this. She thought for all the world she was walking. The easiest way to fix it is I had a gait belt on her. Y'all know what a gait belt is, right? And I took the flat of my hand and I just put it right on her sacrum. And I gave her a little push, just to change her balance. Because walking is the art of not falling down. But they'll do that little shuffle where they're kind of moving, but they ain't really moving through space. So they'll have bradykinesia. Oh look, that was a word on your list today. Depression rarely goes to the black population. I don't know what the genetic marker is that causes that, but I thought that was interesting. Yes?
What about, like, so my grandma's got...
Progressive difficulty with mobility. That's the number one. That's right. Parkinsonian patients are high fall risk. Parkinsonian patients are high fall risk. What do we do for high fall risk patients in the acute care setting? Put mats on the floor. You know what bed alarms are good for, sweetie? Telling you your patient's already on the floor. Swear to God, by the time that thing's got off, they're on the floor already.
And you do frequent checks on them.
Frequent checks. How often is a frequent check?
About every hour.
1 hour. Put them closer to the nurse's station so you can eyeball them.
Take turns with their check.
Please, oh please, oh please. As the disease progresses, that's when they start having nutrition, communication, and behavioral problems. All right, we're going to switch channels. We're going to talk about TIAs, CVAs, and this weird little thing called a rind. Okay? I'm going to back up. First thing we're going to talk about is CVA, cerebral vascular accident, or a stroke. There are two types of strokes in this universe. Ischemic caused by what, son?
The blockage.
A clot. Lack of oxygen because the blood flow's not getting in. So what cardiac diagnosis would put me at high risk for an embolotic ischemic stroke? No, not an infarction. Cardiac history would put me at high risk for an embolotic stroke. Not CHF. AFib. Why?
Because the blood stays stagnant in your atrium, something like that.
It's just swirling around, right? Because the atria is doing this instead of this. Okay? They're at high risk for an embolotic stroke. So, we've got one type of stroke. What's the other type of stroke? Hemorrhagic. Okay? You got a blood vessel in your brain. He has a weak wall. My blood pressure goes way too high, or just God told it to, and all of a sudden you get a pop. You get a blowout in the blood vessel in your brain. What's happening in my head? You're bleeding. Okay? When a patient is showing symptoms of a stroke, there is something, have you guys heard about FAST?
Yes.
What does it stand for? Face, arms, speech, time. What am I going to see on somebody's face who potentially had a stroke?
Drooping on one side.
Right? Facial droop. What else could I see? They lose their speech, their sense of speech, kind of like I'm doing right now because I need more coffee. You can see facial droop in the eyebrows. Asymmetry, it doesn't match. Good job. Arms. What am I looking at? Give my hands a big squeeze. What do you feel on me? On both arms or one arm? Right? So I'm not doing anything here. Yeah. That's why we do the muscle check. Grips and pushes. God gave you two of almost everything. They should be in balance. Does that make sense? So if I go in and go, okay, I need you to squeeze my arms, and only one arm comes up because he thinks he's raising this arm, but it didn't move. There's a problem, huh? They don't realize they're not moving. In fact, one of your buddies was asking me about neglect. I had a patient one time when I was working in PT. He had horrible left-sided neglect. He was sitting in his wheelchair like this. And he could move this hand. And I'd stand over here and I'm like, Johnny, look at me. And I am looking at you, but I can't see you. And I gently bring him back to midline. He's like, oh, there you are. And as soon as I let go of his chin, hemiparesis and left-sided neglect. Okay? Speech also makes me fearful about what? Swallow. If you've lost your capability to make sense talking to me, I'm worried about your swallow. If you think a patient has had a stroke, first thing I want you to do, besides alert the stroke team, call the provider, get a set of files, document mentally or in a notepad somewhere, what time did the symptoms start? That's why we have to know the time. My darlings, you are living in a wonderful time right now in medicine because now we are using thrombolytics to eat those clots, to restore blood flow. They are time limited. Time limited. That's why when a stroke patient hits the ER, you've only got a few minutes before you can use one of those ASE drugs, those enzymes, like Alteplase, ASE, the thrombolytics. They're time limited. So you have to know what time it kicks in. You also better make sure, damn sure, they're NPO. until we get a swallow study done by who?
Oh,
Speech therapy. Good job. So, what's the difference between, well, how do we figure out the difference between a thrombolytic, embolic, ischemic stroke and a hemorrhagic stroke? Nope. CT. Am I going to use it with or without contrast?
with
Without contrast. Think about it. You've got a blowout in the blood vessel, and the blood vessels in the brain.
it'll increase
Now, if
pressure.
you put contrast in there, what's going to happen?
It's gonna keep.
It's going to leak right into the brain cavity, right? What's that going to do to my ICP? It cause more damage. So you think you have a suspected stroke, you alert the stroke team, you do a neurovascular assessment, you call the doctor, and when you give your R, your recommendation, hey dude, can I get a stat CT without contrast, like yesterday? I need it now. Because that's gonna make a difference. If it's not a hemorrhagic stroke, then they qualify for the clot busters. Okay? So what's the difference between a TIA, a stroke, and a RINE? Time. Time. TIA's a trans-ischemic attack. Those symptoms tend to last less than 24 hours. All of a sudden, they're making sense again. They're able to move their body. They're making sense.
Just for the line.
No, TIA, symptoms less than 24 hours. A RINE, the symptoms usually last days to weeks. Days to weeks. A stroke, the symptoms last weeks to months to years. Okay? And I'll tell you right now, my past life working as a PT, if you want that patient to recover from a stroke, the most recovery time they're gonna make is or they're gonna be able to do is gonna be in the first year of rehab. Okay? Many, many moons ago, my maternal grandfather had a massive stroke. And God bless my worthless Uncle Jimmy. He stuffed him in a nursing home because he couldn't take care of Grandpa. And Grandpa had horrible aphasia. What does that mean? Lack of speech or garbled speech. Very good, son. But it wasn't. It really wasn't, because I got a call from a tech at the nursing home years later, a couple years later, and he says, we figured out what was wrong with Grandpa. And I'm like, what? He went walking by Grandpa's room, and he's sitting up in his wheelchair, and he is just blah, 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 blah. All these weird words, blah, 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 and then all of a sudden the tech heard 2 words in German. He walks up to him and he says, Mr. Skidmore, why are you trying to talk to me in German? Grandpa says, in full German, God damn it, I'm not talking to you in German, I'm speaking in plain English. Why am I stuck here? Why are you the only one who understands me? The tech stopped and giggled and said, okay, Mr. Skidmore, say something to me in German. Grandpa clicked, tried to speak in full German, he went straight to English and stayed there. What they didn't realize, because nobody bothered to ask me, because Uncle Jimmy was an idiot, was that Grandpa Skidmore spoke 7 different languages. 7! Okay, when he was in World War II, he was a linguist. All right?
Yep.
His stroke affected what part of his brain?
Well,
Speech center. He'd taken all 7 of his languages, put it in a blender, and went puree. That's why they said he had aphasia. No. He was speaking a mix of his 7 languages. So the reason why I tell you guys this story is because the symptoms that these patients are going to exhibit totally relies on what part of the brain is having a problem. Okay, somebody mentioned earlier today that there was a patient who was sexually inappropriate. What lobe is this?
The frontal
What's it in charge of?
behaviors.
Behaviors.
Behaviors. This is also your filter. This is the one that says be nice in polite company. All right, you lose this. Oh, dear. It's all kinds of fun. They'll swear like sailors. They'll be sexually inappropriate. They may be angry and hostile. This is the patient who's going to take a swing at you. This is the one you want to put you with, want to chemically restrain or physically restrain, yeah. I had a patient many years ago, a little man about this big, weighed about as much as my left leg, had a massive stroke. And I was working on his belly core strength, and so I had him on a big bouncy ball. I'm working on his balance, and all of a sudden, he just started crying. And he real tears. And he started crying like a 5-year-old whose dog got ran over in front of him. He's just sobbing. And I don't know why I'm crying. I don't know. I'm okay, Jamie. I promise I'm okay. I just can't stop crying. I said, that's okay, Mark. I know why you're crying. I know you're not sad. I know why you're crying. You're crying because you had a temporal lobe stroke. Okay? Temporal lobes, high emotions. He had a monster one, and every so often he'd just start tearing up. Couldn't get him to stop. He didn't understand why, but he would just cry like a 5-year-old. Don't forget, this side of the brain affects this side of the body, and vice versa. Okay? If they've had multiple, we're doing this. If they've had multiple TIAs, they are at higher risk for having a big one. If you have a patient who has had a hemorrhagic stroke, you need to do frequent neurovascular checks on this patient, especially the first 24 hours after the event. Because if you go in to check on your patient, and you go in there, and he is just holding his head, and you're like, John, what's the matter? He says, I'm having the worst headache of my life. What's happening? No, he's re-bleeding. He's stroking again. That phrase, worst headache of my life, is going to haunt you guys. You better know it. He's re-bleeding. The worst headache of my life. Except for meningitis, you're not going to see hemichordosis.
That's like a COVID too, that nasty headache.
Okay, so you got a 75-year-old admitted for an uncontrolled AFib. Whoops. She has a saline lock in her right AC. You went in to answer the call light, and the daughter states mom has difficulty with speech and can't move her right side at all. Her history is significant. You like my typo? For hypertension. She states she takes digoxin, aspirin, and cardizem. What you gonna do first? What you gonna do first?
CT.
You better assess that patient. Good job. You lay eyes on that patient. You get a set of vitals, you do a neurovascular check, and then if you're lucky enough, who do you call? Don't you say Ghostbusters.
Stroke team.
Stroke.
Thank you. That's exactly what I wanted to hear. Either stroke team, met nurse, rapid response. Get help now. Do not wait. Remember, time is up. Have you guys ever heard the phrase time is muscle when we're talking about hearts? Time is muscle. If you wait longer, you're losing more heart muscle, right? Time is brain matter too. Okay? Here's your assessment. Glasgow Coma scale. Dude, she gave you an 8. That's not so pretty good.
Her blood pressure's elevated.
7 or less, that means that patient's in a stroke, in a coma. 7 or less means coma. Yeah, you get 8 times to intubate. Vital signs, heart rate is irregular at 132 a minute, blood pressure is 160 over 102. Respiration is 22 and shallow, temp is fine, sats are fine. What does CTA stand for? Clear to auscultation. That means I listen to their lungs, they got good air movement. Huh? What? CT angio? Which one of those gets your undivided attention? Should be 2 of them.
Heart rate and
BP and heart.
Heart rate.
But she has her.
I knew she was going to be irregular, but I'm not worried about that. This is what I'm worried about.
Shallow and blood pressure.
Shallow in the blood pressure.
When did you do an NIH?
Huh?
Is that after? NIH assessment?
I would do that after this one. This is the easier one for me to do. Glasgow colonoscopy. Daughter's really upset that mom can't move her right side. What are you going to tell the daughter?
Get out of the room. I'm just kidding.
I'm just kidding. God, I hope not.
I'm just kidding.
What do I tell her?
Let me work.
Say what?
There's a potential stroke.
A potential stroke? Okay. Can I say mom's having a stroke?
No.
Why not?
Because she's not.
Doctor.
Number one, it's outside of your scope of practice. You cannot diagnose.
You could ask her how long it's been.
Yeah, you're gonna know, I need to know when did the symptoms start. All right? Another reason why you cannot say it's not a stroke is because my x-ray glasses don't work. I can't see in her head. Okay? We're gonna do what? What do I tell her?
CT.
We're gonna check her out, we're gonna alert all the teams that can help, right? What you gonna put in your S-bar? Take 2 minutes, write it out. What are you gonna tell in your S-bar to the doc? Situation, what happened? Here's your magic phrase. New onset. Those are the magic words when something has changed. If you want to get the doctor's undivided attention, you say new onset of blah, 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 blah. Otherwise, he may think, well, this patient's had these symptoms for 6 months. Who gives a shit? Situation, new onset what? What kind of symptoms?
Speech, the time it started.
That's your assessment. What's her background?
Uncontrolled atrial fibrillation.
Uncontrolled atrial fibrillation and, come on, I put it up there twice by typo. Hypertension and hypertension. Then you give your assessment. For vitals, for GCS, for physical assessment. What do you want as a recommendation? She needs what? Immediate evaluation.
CT scan without contrast.
There we go, that's what I wanted to hear. We need an order put in for radiology for a stat CT without contrast, and I need your ass up here evaluating the patient. And I have said that before. I have literally said that to a resident. I need you at that site. And when they sit there and go, I go, dude, you got 2 minutes, get up here. That's exactly it. Otherwise, I'm calling your boss, the attending. Because I have no qualms calling attendings and going, your little boy blew me off.
You're space cadet. That's what everything's called, space cadet. He's semi space cadet.
So we're asking for evaluation, CT without contrast. What else do we need as orders? Hmm? Labs? Which labs you want? CBC? Coags. Very good. Coags. Coagulation studies. Why? Because if she had a history of AFib, she might have been on what type of drugs? Blood thinners, anticoagulants. I want to know if maybe she's got too much. Maybe her lovely and exciting INR was 7.5. Would that put her at high risk for bleeding?
Yes.
Absolutely. Does she need to be NPO?
Yes.
The results of the CT scan are positive for an embolotic stroke. The doctor orders for the patient to be transferred to ICU so they can receive retabase. See the ASE? That's an enzyme. Makes things happen. It's a clot buster. She makes a full recovery because of your phenomenal neuro assessment. Doctor says, keep her stats greater than 92, get a stat serum blood glucose. Look, there's the coags. Start an IV and get that stat head CT without contrast. So, strokes. Most common is the embolotic. Normally caused by atherosclerosis if it's thrombo, means the clot formed in the head. Embolotic, remember an emboli is a thrombus that went on vacation? You started one place and went someplace else. Hemorrhagic, you're bleeding into the brain. An aneurysm is a weakness in the wall of a blood vessel. Doesn't always have to be in your head. Alright? Most common one is in your head.
The aneurysm?
An abdominal aortic aneurysm
It's death.
is another icky thing. No, it's not guaranteed death.
Depending
They
on when
wait,
you.
they wait until it gets a certain length and then they go in and surgically fix it, or you die, one of the two. Does he?
Yeah, for the centimeter.
He's getting lots of ultrasounds, isn't he, baby?
That man just wants to die.
Huh?
I said, that man just wants to die.
Ew. Well, that's one way to do it. An AVM is an arterial venous malformation. It's a genetic disorder. It's a weird looping of the arteries and the veins in the head. I've seen them, most common times it's temporal lobe, and they can surgically repair it if they catch it. My first unsuccessful code when I was a nursing student was a AAA that bled out.
Aw.
No. Risk factors, we already talked about. What are some of the risk factors for stroke? Smoking, hypertension, AFib. How about diabetes? Don't forget, diabetes is a huge risk. We already talked about that. Patients who are coming in with a possible stroke need to be evaluated within 10 minutes of admission. You've got 15 minutes to give the clot buster.
Paramedics here? Oh, those are symptoms, right?
Uh-huh, oh yeah, they'll follow you. I got a possible stroke on its way. Catch. A lot of the clot busters have very short half-lives. And so the pharmacy will send it as a powder, and you have to reconstitute it with sterile water. Okay? So you pull up the sterile water, you put it in the powder, and then you swirl it. Yes? Or we rock. You don't martini shake, because I don't want air bubbles in it. You swirl it, you draw it up, the doctor will say, give it. You administer it. It's gotta be given within 15 minutes of it being mixed. So really have that. Very unstable. Patients who are, when we're doing our assessment, you better be following ABCs, because these patients like to die. Okay? Strokes are nothing to mess with. Cardiovascular history, usually hypertension and AFib. And then we do our neuro assessments. How do I do a quickie neuro assessment on somebody for the cranial nerves? Raise your shoulder. My favorite thing is do this.
Yeah.
Now can you go like this? Give me a dry swallow. Cool. Which cranial nerve did I just check on a dry swallow?
11.
10.
9 and 10. That means if he can give me a dry swallow, everybody above him is intact.
Yeah, this is showing.
Isn't that cool? And then while I'm doing the neuro, I had flash the lights, right? We're doing this. I make a goofball of myself and try and get them to grin at me. Because if I can get them to grin at me, I watch the eyebrows go up evenly and the face go up evenly. All right? I had one dude that was doing it. I said, go like this. You know what he did? He thought that was midline. I went, oh shit. I said, okay, give me a dry swallow. He couldn't. I knew exactly where his stroke was. Shoulder shrug. So, worst headache of my life. You may see hemiparesis or hemiplegia, emotional lability, we already talked about. Vomiting. You got a stroke patient who's puking, you got a problem. Aphasia, respiratory issues, cough or swallow reflexes. Agnosia, this is kind of weird. Hold your hand out for a minute. Close your eyes. What did I put in your hand? Yep. Agnosia is the ability or the inability to recognize a touched object. So if you put a quarter in their hand or a coin, and they're doing this, and they have no clue, you're like, uh-oh. I know what part of the brain that is. They may be incontinent, language disorders, sensory losses. I'm not going to drill you on what side of the brain is in charge of what. Okay?
So what's the difference between this type of stroke and a Bell's palsy?
It's just that it's loss of movement in your facial, my frontal head. It's a loss of like, you can't just. It's a paralysis.
Yeah, boy, y'all got a lot of
Correct.
medical
That's a
issues
good
in
way
your
to describe
families
it.
and
Bell's
shit.
palsy is
This
a
is
paralysis of the
So
facial
it's not a
muscles.
stroke. So, well, how does that, why did that happen?
Think about Botox. You know, if you inject Botox stone and it paralyzes it, but after time it can come back.
It can also be caused by strep. It can also be caused by a freaking cold room. A very cold room.
Oh, like, is it
Room. I had stress. I had a patient who was studying for a test. She was a pre-med student, and she was like getting overworked. So she turned her AC on, super cold, and it only blew on one side of her face. She gave herself Bell's palsy. So good question. Yeah. So nerve paralysis inside of the face.
is it not through?
Sometimes.
Come in, their parents freak out when they're sick. And they'll be like,
Black up against the walls of the carotid to let the blood flow go through. Or they can do the endarterectomy, that rotor-rooter of the carotids, where they cut you from here down to here. So, what is the greatest risk factor for a patient who has a dysfunction of cranial nerves 9 and 10?
Yeah, aspiration.
Cranial nerve 9 and 10. Can you swallow?
Aspiration,
It can cause all those, but the greatest risk is.
What's gonna kill me first, son? There you go. I don't care about constipation. What you guys think?
D or C.
What you guys think? See, because of this. During the first 72 hours after a stroke, we don't have complications. Why? If they've had one, they have a high risk for having another. That means we have to keep close eyes on them. Okay? I love that position. Flat back rest to enhance cerebral perfusion. Oh. Real quick, conjunctivitis. Yeah. Do me a favor, hit the light for a minute. This is what happens to Miss Howard when I use my bare fingers to get the ink off that damn board and then rub my eyes. I have to remind myself I can't use my bare hands to wipe those boards. Okay? If it's bacterial, you're going to see blood vessel dilation. We need to focus on prevention. Cataracts, the lens of the eye. It's cloudy. All right? So the image being projected onto the retina, that's why they lose their vision with cataracts. Can we fix that?
Yes.
Absolutely. What do?
Surgeries.
Yeah, we do a lens transplant. Just a lens transplant. This is what they see on cataracts. Do you guys see the difference? The little patches? That's where the cloudiness would be on the lens.
That sucks.
Glaucoma is because of the intraocular pressure. Remember, your eyeball is full of fluid. Okay, when there's too much fluid in there, it causes the lining to swell up, and that's what causes. Now, primary, it affects both eyes. Angle closure glaucoma is usually caused by a trauma, and it is an emergency. That patient needs to go to OR, they numb the area up, they stick a needle in there and drain off some of that fluid before the eye, the back of the eye, the retina peels off. So they have a visual field impairment, decreased accommodation, halos around lights. Lots of good drug therapies are out there to decrease the intraocular pressure. Macular degeneration, there's either dry or wet. Alright? The wet, the reason why they call it wet is there's an injury followed by new blood vessels being formed because of the injury. Did you notice it's the center of his field of vision that he's lost? How do we manage them? Decrease the blood vessel damage by reducing the hypertension. Glucose control. This is diabetic retinopathy, guys.
Oh.
And then there's hearing impairments. I figured while we were on the shoulders and up, I just slapped the eyes and ears in there real quick. I got a question for you. Straight up. Should I ever put anything in my ears? No. There's only two things you're allowed to stick in your ears. You ready?
Water.
Your elbows. If you can figure out how to get your elbow into your ear, knock yourself out.
I used to like sticking stuff in my ears and nose when I was a kid. I went to the emergency
Kids do
room
that
at the
all the
time.
time. It makes me crazy, man. If they've got an orifice, they're gonna stick something in there. Okay? The only thing we should be putting in patients' ears is to either look in to the otoscope, okay, or liquids to flush it, okay, or liquids. Cerumen is the wax. 99% of the time hearing loss is caused by that, not aging. Alright, and then we got kids who like to put shit in their ears. Or seniors with dementia. Alright,
Lux is extremely serious. My husband just was.
oil. Don't take it out of the fridge and pour it into somebody's ear because you're going to cause a seizure. Alright?
That's why whenever we clean kids' ears, you have to make sure the water is warm with a certain amount of hydrogen peroxide,
Water.
because they can see.
Yeah, they will seize. Okay? And then you use, okay, y'all remember, y'all took OB, right? You know that little that blue squeegee?
Yeah.
That we, the snot sucker? You can use one of those on the little babies, and instead of holding, fill it up and use it to dispense. It's very gentle.
We usually just get
Syringe?
20 cc with the hubcap from the IV.
Horribly debilitating. Horribly. It is vertigo to the nth degree, to the point where they're puking. It will take days for them to recover if they're having a vertigo attack. It distorts the balance of the liquid in the inner ear. That's what I'm saying. He needs to be screened from the air. Alright? And I'm not talking a little bit of tinnitus where it's that little funny. I'm talking, it sounds like an 18-wheeler behind you stepping on the horn. It is loud tinnitus. It's a mismatch of the balance of the fluid in the inner ear. Not a good thing. How do we take care of it? Number one, teach them to move slowly. If that vertigo makes them a high fall risk, they will fall down, crack their head. Drug therapy. There's something called a Manette device. I haven't seen one in years, but it looks like, you remember how I said a pacemaker looks like two silver dollars stacked one on top of each other, or two poker chips stacked on top of each other? A Manette device looks like two dimes, and they literally implant it under the skin, behind the ear, and it's got a little bitty electrical shock associated with it. that helps get rid of the extra fluid. Okay? Worst case scenario, you ever seen an adult with tubes in their ears? That's the surgical fix. All right, let's take a break.